in your institution, are people doing neoadjuvant treatment? Meaning you give, let's say, 2 doses of PD-1 and then going to do surgery in some of those patients, or
Yeah, I think this is one of the most kind of exciting, kind of hot off the press areas where the practice is really kind of changing in real time. And this is in large part to Sapna Patel, Dr. Patel, who led a SWOG neoadjuvant study that was randomized. Now, we've had a number of single-arm neoadjuvant studies that have shown a lot of promise, and importantly, prognostic factors based on the degree of response in the lymph node. So you get, and just to sort of clarify, right, neoadjuvant just means you're getting.
Yeah, why don't we explain to people what neoadjuvant means, and before we got into this.
So you're getting a drug therapy. We kind of talked about the adjuvant piece, the drug therapy piece, but instead of getting it after surgery, you're getting some component of it before the surgery. So it gives us sort of a real-time look into how effective or not the therapy is. Because with an adjuvant trial, the cancer, all the cancer we can see has been completely removed.
Sure.
And so if your cancer doesn't come back, to be fair, we're not sure, was your cancer just cured with surgery alone, which a good number of patients are, or did the adjuvant therapy help you in some way? And there's really no way to tell for any individual patient. But for neoadjuvant therapy, we get kind of that early biomarker that when the surgeon takes out a lymph node, and I should say this is a certain group of stage 3 patients.
Why don't we clarify that? What stage 3 are we talking about? And I should have asked that question in that fashion, but go ahead.
Yeah, so many of our stage 3 patients are stage 3 because they were diagnosed with a melanoma on the skin that was a certain depth. The surgeon did the sentinel lymph node procedure, and that came back as showing microscopic amounts of tumor in a lymph node. And I would say that's a big proportion and probably how most stage 3 patients are identified. But a certain number of patients present with a node that we can already feel or someone can already see on a scan, and we call that macroscopic disease. And that's the group where we're really talking about neoadjuvant. So neoadjuvant doesn't apply to the sentinel node positive patients because there's no way to know if they have positive disease in the node until the time of surgery and pathology. So the neoadjuvant patients can get some therapy ahead of time, so before surgery. And when the surgeon takes out the lymph node, the pathologist can look at it under the microscope and tell with now pretty good data about the degree of effect of therapy, meaning how much live cancer is left versus how much is dead tumor. And the percentage of that appears to really correlate to prognosis and how patients will do. And so we get sort of an early marker, which I think can be really helpful for the patient, and the clinical team.
Yeah, it kind of logically kind of makes sense because, you had the tumor burden and you give immunotherapy so that you basically have better the immune system is able to mount a better immune system to attack it because there's a large burden tumor present when you go through the immunotherapy, when you go through the neoadjuvant. In contrast, if you go through the adjuvant, you already remove the bulk of the tumor, then you give the immunotherapy, the immune system may not see as much of tumor, so sort of have that's one of the kind of benefit, the rationale we think why neoadjuvant is successful, basically.